Welcome. In today's masterclass, we are going to get really good at spotting the key pleural abnormalities on a chest x-ray. Let's jump right in. So, here's our plan for today. We'll start with a normal x-ray to get our bearings, then we'll tackle pleural effusion, pneumothorax, and the combination of the two. And of course, we'll finish up with a high-yield recap just for your exams. All right, first things first. You can't spot what's wrong if you don't know what right looks like, right? So it is absolutely essential to know the normal chest x-ray inside and out. This is our baseline. Okay, let's take a look. Right in the middle, see this dark column? That's the trachea, filled with air. Just behind it, you can make out the vertebral spine. And this big shadow here, that's the cardiac silhouette, the heart. You've got your aortic knuckle, the left heart border, and of course, the ribs wrapping all the way around the beautiful lung fields. Now, Bacho, I want you to focus on this one specific area. Down here, where the diaphragm meets the ribs. This is the costophrenic angle, or the CP angle. See how sharp and pointy it is? It has to be sharp. Burn this image into your brain because this is the first place we're going to look when we suspect trouble, especially any kind of fluid. Okay, so let's get into our first major pathology, pleural effusion. This is all about fluid getting into the pleural space. And when you see it on an x-ray, think whiteout. It's actually pretty simple. Pleural effusion just means you have fluid where it shouldn't be, in that potential space between the two layers of the pleura. This fluid could be anything: transudate, exudate, blood, even pus. So how do we spot it? You have to look for three classic signs. First, that sharp CP angle we just talked about, it's gone. It gets blunted or completely obliterated. Second, you'll see this uniform white shadow, or what we call a homogeneous opacity. And third, the top edge of this white area isn't flat. It's curved, like a crescent. We call this the meniscus sign. This triad is a very, very important Viva question, so remember it. And here we have a perfect example. See? That sharp CP angle has completely disappeared. It's blunted. In its place, you see this dense whiteness. Now, look closely at the upper border. You can see that beautiful classic curved shape. That is your meniscus sign. Now, what if it's not just a little bit of fluid? What happens when a simple effusion becomes a massive one, filling up the entire chest cavity on one side? Well, then the signs get even more dramatic. When you have a massive effusion, one entire side of the chest, one hemithorax, will be completely whited out. But here is the critical finding, the one you cannot miss. All that fluid has mass, it has weight. It physically pushes everything in the middle, the trachea, the heart, the whole mediastinum, over to the opposite healthy side. Just look at this x-ray. The entire left side is a complete whiteout. And now look at the trachea. It's supposed to be in the center, but you can clearly see it's being pushed far over to the right. It's running away from the fluid. This is the classic picture of a massive pleural effusion with a contralateral mediastinal sift. All right, let's completely switch gears now. We've just seen how fluid creates a whiteout. Now let's see what happens when air gets into that same pleural space. Instead of a whiteout, we get a blackout. This is pneumothorax. So the problem here isn't fluid, it's air. Air has leaked into the pleural space, which is supposed to have negative pressure. This breaks that seal, and the lung, which is elastic, just collapses in on itself. So what are we looking for on the x-ray? The number one sign is an area that is jet black, much blacker than the normal lung tissue. Why? Because it's just air. There are no blood vessels, no lung markings. And if you look carefully, you'll be able to see the edge, the sharp line of the collapsed lung itself. See here on the right side, do you see how this area is jet black? And very importantly, there are absolutely no fine white vascular markings in here. It's just blackness. And then you can trace this fine line. That is the edge of the collapsed lung, a perfect pneumothorax. Now, a simple pneumothorax is bad, but it can get much, much worse. It can progress to something called a tension pneumothorax. This happens when air keeps getting in but can't get out, like a one-way valve. This is a real, true, life-threatening medical emergency. And what's fascinating is that the x-ray finding is actually quite similar to massive effusion, but in reverse. You get a jet black lung field over the entire hemithorax. And just like before, the mediastinum gets pushed to the opposite side, but this time it's not fluid pushing it, it's air under extreme pressure. This right here is a classic exam image. You'll see it again and again. You have this extreme blackout on the right side. But look at the mediastinum. The trachea is pushed way over to the left. This isn't just a pneumothorax. This is a tension pneumothorax, and it needs to be treated immediately. So, we've covered fluid, which is white, and we've covered air, which is black. So the obvious next question is, what happens if you get both air and fluid in the pleural space at the same time? Well, that gives us a very special condition called a hydropneumothorax. So if that fluid is blood, maybe from trauma, we call it a hemopneumothorax. If that fluid is pus, maybe from an infection, we call it a pyoneumothorax. But the principle is the same, air plus fluid. Now, this condition has one pathognomonic sign, one finding that screams the diagnosis, and it is this beautiful, sharp, perfectly straight line. This is an air fluid level. Because you have air on top and fluid on the bottom, gravity creates this perfectly horizontal line. Remember the curved meniscus of a simple effusion? This is completely different. It is dead straight. Okay, everyone, time for a quick-fire revision. Let's hammer home the key differences between the two big emergencies we talked about, massive pleural effusion and tension pneumothorax. This is super high yield for your exams. This one slide is pure gold. If you remember anything, remember this. Massive effusion gives you a whiteout. Tension pneumothorax gives you a blackout. In both cases, something is pushing the mediastinum. And the rule is so simple. The trachea always shifts away from the problem. So it shifts away from the white in an effusion, and it shifts away from the black in a pneumothorax. Both are bad, but never forget, tension pneumothorax is a top-tier medical emergency. And there you have it. We've gone from the normal baseline all the way to spotting life-threatening conditions. You now have the fundamental signs to confidently look at these chest x-rays. So the next time you're on your clinical rotation, I want you to look for these signs and be the one who spots them first.